Good evening, Professor Dr. Ranjan Sharma, sir. Thank
Good
you for
evening.
joining, sir.
Good evening.
Good evening, sir.
There
Good
is some
evening.
problem in my network issue here, so there may be some disturbance in between from my
Yes,
side.
sir. Mr. Devajoti informed me, sir. No
Yeah,
problem,
yeah.
sir. Yeah.
Okay.
Good evening, Dr. Ankur Gupta, sir.
Hi, good evening.
Thank you for joining, sir.
Yeah.
So, Dr. Gaurav, sir, if you allow, we shall start with the session now.
Yes, please go ahead.
Sir, I would request you for 1 to 2 minutes of to introduce Translumina, what is Translumina is all about.
Absolutely, go ahead.
Thank you, sir. Good evening to all our faculty members today. On behalf of Translumina, I would really like to thank you all for taking your time out from your busy schedule. And myself, Garima Bhatia, I am in medical marketing department of Translumina for India business. So before going towards the session, I would just like to throw some light on what Translumina is all about. So a company with the limitless possibilities. Integris MedTech, basically, it is an India's leading diversified MedTech platform for global emerging markets, wherein it has been divided into two of its commercial segments. That is Everlife, which is a leading lab and analytical equipment platform for Southeast Asia. And Translumina is a leading cardiovascular solutions provider in emerging Asia and Europe market. So our Integris MedTech is divided into cardiovascular in vitro diagnostics, scientific lab solutions, and has been positioned as number one player in scientific lab solutions in Southeast Asia, whereas number two player in stents in India business, and has taken approximately 18% of the market share in coronary stents in India. An unparalleled market access, which says 2,000 plus hospitals and cath labs have been directly covered, with 17,000 plus laboratories and 350 plus distributor partnerships across 60 plus countries. And our strong R&D and manufacturing facilities lies wherein 100 plus SKUs are being manufactured, and 7 micro manufacturing centers are there in India and Europe itself, with 2 R&D centers. So these are all basically our tech transfer distribution products, which is Shockwave, Sys Medical, Kanika Assist, Chemonetics, Asahi, and with our in-house manufacturing products as well. So our, as I've mentioned, the second largest player with basically our diversified manufacturing facility lies in India, Germany, and Netherlands. So to basically initiate with access, assess, prepare, and treat, we have all our product ranges with our treat solution for the patient, Yukon Choice, Vivois are in Protege, and recently Medinol, that is Elunir Pearl, has been added in the portfolio. Just a few, 1 to 2 years back, Translumina has acquired an innovative solution, proven next generation drug coated balloon technology by handing over basically from the Blue Medical to Translumina. The tech transfer has been taken over for Protege, that is Paclitaxel coated balloon dilatation catheter with a global presence in more than 35 countries. R&D team is light at basically Netherlands with a manufacturing facility as well. And Protege is EU MDR certified with patented drug application process. So Protege with unique drug application process, whereas we have used autopipette for coating the balloons with minimal drug loss during the transition. Wing seal technology, which has corrugation over the surface of the balloon, which actually ensures that effective drug delivery to the lesion site. And M3I, that is multiple inflations up to 3 times with the same device in the same vessel. And Protege is also one of the world's first, basically the only world's first non-compliant DCB available with Translumina. So again, I would like to thank you all our faculty, respected faculty members for joining. So our this is our agenda. I would like to thank Dr. Gaurav Verma sir and Dr. Ranjan Kumar Sharma sir. Thank you. Dr. Professor Ranjan Kumar Sharma sir is basically will be leading our DEB talks as a chairperson. He will be giving our insights on DCB. And Dr. Gaurav Verma sir, thank you so much for taking over the session, sir, and sharing your insights in the upcoming sessions. Thank you, sir. Over to you, sir.
Hello, hi. Good evening, everyone. So it's given me immense pleasure to be moderating this session on DCBs. We all know that DCB has taken a center stage now whenever we talk about angioplasty, and with the time we have improved both in terms of technology as well as our acceptance for DCBs. And with time, probably we'll take a full circle, like we started with just a POBA era in 1970s, and then we moved on to stents, starting with bare metal and drug coated. And now again, we are moving to balloons, so that we should maintain the normal architecture and the endothelial function of the arteries. So just to highlight the importance that of late, the usage of DEB has increased tremendously, and especially for ISRs and side branch, they have become the treatment of choice. But probably with the time to come, we'll have a better technology to even give us the confidence to use them in the main branches and the left main subsets as well. But we still have to wait for that. So without much ado, I'll try to call upon my chairperson as well, and he's a speaker as well, the well-known Dr. Ranjan Sharma. He's a HOD from Manipal Hospitals in West Bengal, and I'd like him to deliver his talk on the lesion preparation. Over to you, sir.
Good evening, everybody. So this is a very exciting area of our what I say, intervention in cardiology, because we had been, I was trained once the stents were not available. So we used to do plain balloon only. And now we are again playing with the plain balloon, but with a drug over it. So let us, well, its use will be more and more over the time. So we need to prepare the bed quite efficiently, properly, so that the need for stents are not there and the patients are benefited by use of these DCBs. So this is the step-by-step approach. You have to deliver the drug by the balloon. Balloon is not for dilation of the lesion. So you have to dilate the lesion with a semi-compliant balloon. And I prefer a non-compliant balloon with a 1:1 ratio. Only semi-compliant can be used if the patient is ACS. Although ACS, the guidelines, it's not recommended, but if someone wants to do it, in ACS condition, we can do semi-compliant. Otherwise, I will prefer a non-compliant balloon. And you can sometimes use rotational astectomy or intravascular lithotripsy for plaque modification. So your upfront planning has to be that you are going for DCB, not for stents. And you have to confirm that the balloon is inflated in fully. There is no dog boning. And you have to see in various views, at least into orthogonal view, there should not be any dog boning. And aim for a residual stenosis which is less than 30%. And it is very difficult sometimes in osteal lesions, but otherwise we can achieve in most of the patients. And ensure a TIMI-3 flow before applying for DCB. And if dissection is there, it is useful for the patient because there will be better drug related to the tissues. But type C and higher dissections are not welcome. And if it is there, then you have to go for stents. This is just illustration. You can see you have to aim for 1:1 dilatation, rotablation, atherectomy, lithotripsy can be done.
Just to interrupt, Dr. Sharma, we are not able to see your slides.
You are not able to see.
Yes.
Oh.
You have to click on that PowerPoint probably. Garima, can you help him?
Yes, I thought sir is just giving his insights first. Sir, please double click the presentation name, best practices, if you want to show this slide. Yeah. Double click.
Yeah, this is the.
So first click on share. If you can see the share button is there on the screen.
Share is there.
Yes, sir. Now
now you can
which
see?
presentation? Yes, sir. Can you click on the slideshow, sir? The bottom one, yes, sir.
Yeah, it's okay.
Thank you so much, sir. Yes, sir. Thank you.
Sorry. So here this is a here only. If you have dilatation has been done with a 1:1 diameter balloon, vessel diameter and the balloon, and you have acceptable result. There is no flow limiting dissection, residual stenosis less than 30%. If for some say more than 0.8, you can go for DCB. If it is not so, then you have to go for DES or vascular scaffolds. So significant recoil can happen sometimes. If it is more than 30%, then you have to go for stents. Flow limiting dissection has to be excluded. Sometimes you may need to do a intravascular imaging to see what is the nature of the plaque and any dissection, if it is one doubtful whether it's higher or not. And if there is any chest pain or ECG, you have to be very, very sure that it is not due to dissection. And FFR can guide sometimes, and if it is more than less than 0.8, you can go for DCB. So this balloon is not for drug delivery. It is only for there is only for drug delivery. It's not for this thing lesion dilatation. So you have to inflate the balloon only at the nominal pressure, and you have to handle the balloon quite properly, because if you touch your balloon with your wet fingers, gloves, then there can be some wastage of the drug. And if you take a lot of time in taking the balloon to the site, it can be that drug can be lost during the transit in the guide catheter. And the length of the balloon has to be at least 5 millimeter longer than the lesion that you have dilated. You have to be on 3 millimeter on either side of the lesion, so that you are not missing any diseased area. And you inflate at a nominal pressure and maintain for at least 16 seconds, because it will take some time for drug to be delivered to the tissue. And you may sometimes go just one ATM higher than the nominal, but it is not recommended that you have to go. The higher the pressure, you will feel that the higher drug will be delivered. It's not so. So you have to give nominal pressure only, and that balloon diameter has to be 1:1 with the vessel, diameter of the vessel. And one should avoid post dilatation. So you prepare the balloon lesion beforehand. And if you are very, very comfortable that your lesion is well prepared, then only you go for DCB. Sometimes, suppose the artery is highly tortuous and calcified, and there is a distal disease, it may take some time or there can be some difficulty in negotiating the balloon down. These balloons are not as good as the deliverability or trackability is not as good as usual balloons. So it may be there can be some difficulty in negotiating. So sometimes you can take a guideliner or a mother-in-child catheter, so that the guideliner is close to the lesion, and the balloon can be DCB can be delivered to the site quite quickly, so that the drug loss is not there. And once lesions are type 1 A and B, then you can go ahead with the DCB. Bailout stenting only, if I have said already, no flow leading sections. You just closely observe, and then you go ahead with the DCB. In bifurcation lesion, again, it can be done, but scoring balloon is preferred because osteal lesions are quite tough, fibrotic. So you need to have a scoring balloon for these osteal lesions. Sometimes for diffuse long lesions, suppose in LED you have a proximal tight stenosis and diffuse disease lower down, and putting long stents and overlapping stents, you end up with too much of metal in the patient needs CABG maybe in few years. Then the surgeons will have a problem. So you can go for a DCB distally, and proximally you can put a stent. So this hybrid strategy is quite good for these DCBs. So this I've already answered this discussed, and let us go to one of my case that I just did about 6 months back. So I will just show one case here. Can you see my slide now? Can you see my slides?
Yes, sir. Yes, sir. Just
Yes,
the slides,
go ahead.
sir.
Yes. So this is a patient who had multiple ISRs. This Sorry, I cannot see the. I'm not able to see what is the problem. Just initiating again. Just a minute. It's okay now? Can you see now?
Yes,
Sir, yes, sir.
Yeah. So this is the patient who had a angioplasty done quite long back in Punjab. He had a proximal radial stent after ACS. The length and diameter was 2.75 into 24 millimeter. And after 9 months, he had a recurrence of angina. So another DS was put. It was slightly longer, 2.75 into 28 millimeter. And he had recurrence of angina in June 2025. So this was his shot. You have some disease in the RCA, but not very critical. But you can see there is a retrograde to the LAD and diagonal beyond the stent. You can see the stent in the LAD. By retrograde, there is large D1, D2 as well as the LAD. So this is a lesion in the circumflex, which is needs to be done something, and you can see there is a LAD stent which is diffuse ISR distally, and then there is nothing is seen beyond that. So beyond the stent, there is a total occlusion of the LAD as well as a large D2 that was visualized from the RCA collateral. So I just went ahead. So you have already two layers of stents, and you have a large LAD distally with a large D2. So you have a bifurcation issue there, and an ISR which is already. So DCB was right from the beginning in my mind. So I started with planning to cross into the LAD, but the wire was not crossing into the LAD, but it went into D2. I tried many wires, but I failed to negotiate. Then I just thought that some plaque modification by a small balloon can do the trick, but multiple attempts after this small dilatation at the junction of D2 LAD or origin, I just could not go. So what I did was I did a balloon occlusion technique. Again, it failed. So I had to take help of this crusade catheter, dual lumen. And at this, I could cross the Sion blue wire. You can see the wire went into the LED, and you can see there is a wire in the D1, D2. And the vessel, dilatation was done serially with 1.2 into 10 millimeter at LED D2 bifurcation. Thereafter, 1.5 into 12 millimeter, you can see the result here. Some flow. And then with a 2.5 into 10 millimeter Wolverine coronary cutting balloon into LED at the junction with the stent. And then 3 into 10 Scoreflex balloon for the LED stent. It was a 2.75 stent, but I went ahead with a larger balloon with aggressive dilatation, and then I did with NC balloon multiple dilatation, so that the balloon, stent is well expanded, and some residual whatever atheroma is not there. Then I did a Wolverine to the D2 also with same balloon, 2.5 into 10. Then after the bed preparation, you can see there is some better flow, but not ideal, but I had no choice. You already have two layers of stents in the LED, and then you have bifurcation lesion. So I just went ahead with the protege to the D2 first. It was 2.5 into 20 millimeter. You can see the result here. Some disease in the just after the ostium. And then I did a 2.75 into 12 millimeter NC balloon at the LED lesion. Then I went ahead with a protege balloon to the 2.75 into 20 at the LED bifurcation. And then 3 into 30 protege to the LED. So you had two DCBs, one into the D2, one into the LED, and one in LED distal to the stent. And inside the stent for ISR, I just applied 3 into 30. You see the result. So this was still, may not be very ideal, but still that was the best that I could have hoped to do. And then I did dilatation of the LCX. And I thought that maybe the DCB would be enough, but I went ahead with the stent. This was the result of the stents. So limitation and criticism in this case, I did not go ahead with the intracoronary imaging because it was not available in my lab at that point of time. I could have gone for some orbital or some sort of atherectomy should have been done at the bifurcation because there was a lot of calcium there. Ultra high pressure balloon could have been as good as the NC balloon as a cutting balloon, but it was not there in my lab at that point of time. I didn't go ahead with the kissing at the LED due to bifurcation. You can have some debates on that. Whether I should have put a DCB for the LCX, and I applied paclitaxel for this. Whether Limos would have been better, we can have some discussion on this. So the major reason for repeat target revascularizations are improper intervention at the first place. Availability of the intracoronary imaging and atherectomy devices in these cases are mandatory. Proper control of blood pressure, diabetes, statins, gas blockers, all these are very important. And I believe that DCB has a great future. We need properly designed trial to explore their full potential. Thank you.
Thank you, Dr. Sharma, for a very edifying and highly thought-provoking session. Now, probably the session is open for discussing more new things in DCB, like with your awesome case. Only small thing I just want to ask, if you permit, that he had two stents before, right? Two layers were there. So probably just imaging would have helped you more in choosing the better size. And secondly, in these cases for bifurcation, like you also had a small query that whether we should do with two kissing balloon dilatation with two simultaneously DBs. So again, that need to be explored. We still don't have a data to suggest we should go ahead with two balloons simultaneously or not. One more thing I just want to ask, suppose we have a longer lesion and you have a smaller length of the balloon. Can we reuse it? Because proteges have a advantage to use three dilatations. Still, at the third dilatation, you have a sufficient drug to coat the area.
It is very, I say, very appealing that you can dilate the vessel at this thing two, three times. But the problem is, suppose you have taken a 30 millimeter protege balloon and you are dilating the distal part of the LED first. So you will be taking a 2.25 or 2.5 millimeter balloon. And once you come proximally, most likely the proximal diameter would be much more than, or maybe more than whatever you have taken. So the tissue, the balloon may not be touching properly and the drug delivery may not be there. So I don't go for three dilatations. I can have maybe two dilatations. I am comfortable, but coming proximally and it can be there for RCA. It's okay because there is not much of change in the vessel diameter. But mostly we are this type of things we usually go for LED. That is my experiences. Most of the times I have done this 2-3 dilated balloon application in LED only because you generally I try to avoid the LED distally stent so that if the patient needs CABG in future, the surgeon can put a graft. For RCA, we can very well do this 2-3 times. And your comment about your kissing this thing, the problem is delivering two balloons, it takes a lot of time at the bifurcation. And by the time you might be losing some of the drugs, why one balloon can rub against another, and maybe I don't know whatever drug loss is there while passing. Intravascular imaging, I have already said, whenever I am dealing with or any person is dealing with a ISR, or you have a visible calcium there, you have to have a imaging so that you can have the atherectomy tool, whatever you need, IBL or orbital or rota, whatever. So imaging is a must, but it was not there in my labs, so I had to go ahead with the angioplasty. But I knew the diameter of the stent, it was 2.75. So I just cannot go more than 3. So that was the maximum I could have gone. So I thought at the first place, the diameter of the stent was smaller. And that was the reason for this ISR. I'm not sure the reason.
Thank you, sir. Excellent presentation. And probably you have set the stage set for the typical use, ideal case for a DEB with a ISR and small size vessels, diffuse disease. I mean, these are the probably the ideal indication what we used to falter before by putting again a stent or subjecting the patient for CABG. Now with the DCB in our armamentarium, we are quite happy to use them with a good result. Probably your patient must be doing fine. You must be
Yeah,
having a
yeah.
6 month follow-up of him.
6 months, yes. Patient came a few days back and he's absolutely fine.
Fine. So you one
I,
query
I,
of
I,
yours.
bel I believe this paclitaxel, the vessel diameter that I ended up with, you
It
you
must
can
have
have it.
increased.
Yes, it can increase. I'm not sure. So I wanted to do angiogram to this patient, but patient
We'll
refused.
be eager to see the angio again in your next
Yeah, yeah.
presentation, probably.
I was keen to do and see whatever is left. Yeah.
Thank you. Thank you, Dr. Sharma. So probably one more query of his was that whether to use paclitaxel or sirolimus. And for enlightening on that, we do have a speaker on this topic as well. We have Dr. Tanuj Bhatia with us. Tanuj is around?
Yes, sir is around here only. Sir has joined. So there
Okay.
is a query. I think Dr. Ashish Govind sir wants to say something. So he has raised his hand.
Of course, please go ahead.
Yeah, thank you for the nice presentation. So, regarding the question which you asked, Dr. Gaurav, that using two balloons simultaneously as a kissing using DCBs. So, recently a publication has come up in the JAC, I think 2 months back, with the ARC guidelines, not a guideline, but ARC recommendation regarding the DCB usage. So they have clearly mentioned that using two balloons simultaneously DCB is not recommended at all, because in the proximal segment the drug is not delivered optimally. Some part of the artery is not coated with the drug because of the opposition of the two balloons. And secondly, there could be a chance of dissection. So using two DCBs together as a kissing should be completely avoided as
Okay.
far as possible.
Great. But of course, when you do simultaneously, there is chance of losing the drug and side, with the pinching also. Once you are dilating the side and then you're doing the main. So one thing what we can suggest is you can do, simultaneous kissing. That you have both the balloons simultaneously. You first dilate the side branch, then the main branch, and with a minimal pressure, you can come out with both the dilation, maybe a 4 or 6. That may serve the purpose of the concerns what you have raised. So nice insights. Thank you, Ashish. So we'll move forward, and I'd like to invite Dr. Tanuj Bhatia. He's HOD Cardiology in SGM RMC Hospital, Uttarakhand. So all yours stage, Dr. Tanuj.
Yes, thank you, sir. So I'll be presenting one case. It's a interesting case where unexpectedly I used a DCB at a site where I was not planning to in earlier, and I'll try to. Is my screen visible?
Yes, you can just do full screen.
Yeah. So the topic is when the culprit is not the obstruction, and how IVUS changed our modality. And in all bifurcations, but more so in left main bifurcation, we do have a non-tubular morphology, and the stent design, the drug-eluting balloon, they need detailing. It's a highly complex thing, so we need to delineate the morphology before we move ahead. So my case is a 65-year-old female, extremely non-compliant to therapy. She underwent a angioplasty to LAD for a anterior wall MI around 1.5 year back. Again presented to us in with stent thrombosis. Again a repeat PCI to LAD was done, and this time this case is around 2 months back. It was November. The patient was having chest pain for past 4 hours. She had stopped all drugs including statin, and this time her blood pressure was 60 millimeters of mercury. The pulse rate was 76, and I'll show you the ECG. Was ST elevation in lead 1, lead AVL, and there was ST depression in V2 to V6. And this was the diagnostic angiogram. Is the screen visible?
Yes, go ahead.
Yeah. So this was the diagnostic angiogram. So we have a stent placed in the proximal LAD that has proximal critical disease.
Tanuj, sorry to interrupt. Your screen is lagging. We have just seen the ECG now. Yes, now it's fine. Now we are seeing the angio.
Is it okay now? Should I
Yes,
continue?
yes.
Okay. Give me a moment to just check my internet. I think so. It's okay. From my side, it's okay. Should I continue?
Yes, sir, go ahead.
Yeah. So this is the angiogram that shows there is a proximal edge restenosis in the LED, and the culprit is possibly the left circumflex. So this time we have a left circumflex which is occluded. So I'll take you back to the index angiogram. The Medina is 011 strategy. I'm still figuring out how to go ahead in such a critical patient. I'll just take you to the index case so that we know that the LCX was absolutely non-diseased. It was a standard anterior wall MI that we see in a routine fashion. So at our place, we use a lot of penumbra for aspirating these thrombus. So this was the index PCI that I'm showing. So we did a penumbra thromboaspiration back then. Thereafter had a good flow towards LED, but some of the thrombus had embolized to the diagonal. So we aspirated that thrombus too at that time, pre-dilated this lesion, and placed a 3.5 stent in proximal LED. We did not do imaging at this point of time, post dilated it well. So at least you can appreciate that the stent is definitely not undersized or underexpanded. And in the caudal view, I might even say that it was a bit aggressively post dilated at that point of time. So the patient was doing fine. Her LDL is 139, but she does not take statin. She still takes antiplatelets, but she does not take statin. So these are the still images of that time. And coming back to what happened in November 2025, 2 months back. So we have a proximal edge ISR, stent looks expanded, possibly a biologic cause. LM is not that disease, but LCX, which was beautifully normal, it has a total occlusion. We presume that to be the culprit, and you have a ostial LCX critical ISR. Medina, though very, very good, but does not tell me about the plaque distribution and length, does not tell me about the bifurcation angle. And like in most of the cases, we do have some dilemmas, which vessel to go first. Definitely it's LCX in this case, which strategy I would follow. So again, we are very fond of penumbra. It actually debulks the thrombus. So we just hooked the vessel again, passed a wire towards left circumflex, aspirated that thrombus, then passed towards the next OM, aspirated that small ramus, aspirated the thrombus from that also. You can see the wire going to the major OM. The patient was very, very sick till that point of time. The 5.3 French penumbra traverses easily across these vessels, and just after that the patient's blood pressure restored, the hemodynamics improved, the blood pressure came back to 130/80. We had a reperfusion arrhythmia documented at that same moment, immediately when the patient was revascularized, and this is thereafter we took the IVUS pullback from the left circumflex. So you can appreciate this is the still L mode downstairs and the pullback and the still images. So just to demonstrate, after aspiration of the thrombus, there was extremely minimal plaque in the left circumflex. The MLAs were pretty good. Possibly the distal vessel, it was appearing healthy, it was free from any plaque, and the L mode shows beautiful osteo of both major OM and right at the osteo of LCX also. Thereafter we move towards imaging LED. So this is the LED pullback, and right at the ostia where we saw a very, very critical disease, this is that area. So this is hypoechoic. It is not even a standard fibrotic plaque. It is either a very, very lipidic plaque, or more so in hindsight, I feel it is possibly a subacute thrombus. And in the L mode also, you can see this bright echolucency, which is seen on the cross section as a echolucent. It is just abutting the lumen. This is the pullback and thereafter. So this is either a lipidic neoatherosclerosis with a large necrotic core, or possibly seeing the timeline, it might be even a organized thrombus. Mid LED shows 2 layers of stent struts. Thereafter, this is just the IVUS pullback. So thereafter, we did a pre-dilatation towards LED with a high pressure 3.5 mm NC balloon. And this is that result. So since it was a lipidic new atherosclerosis, our strategy had already changed. This is a slightly longer stent length, then we pulled it back and we took a smaller stent. So we took a 3.5 into 18, matching the distal diameter of the vessel, placed it right from the LM ostia, in placing it in the iliocranial view, 3.5 into 18. Post dilated, did a pot with a 4 mm balloon. You can see some slight pinching of the ostial LCX, but we first did a appropriate pot, recrossed the wire towards, this is the pot sequence, recrossed it towards left circumflex, did a 2.5 did a sequential 2 followed by 2.5 mm dilatation of the side branch struts. Thereafter took a IVUS pullback again, did not demonstrate much of plaque at the ostial left circumflex, and we completed this procedure after a KISS with a 3.5 NC and a 3 mm NC balloon in the ostial left circumflex. We completed this case with a KISS with a drug-eluting balloon. I'm sorry for the lag, just give me a moment. So finally, we did a case with a 3.5 mm NC in the LED and a 3 NC in LCX, and finally replaced that NC with a 3 into 15 drug-eluting balloon for completing that case in the left circumflex. And this is the final pot thereafter that we did, and this is the final result. We had some slight under expansion in the mid LED stent, completed that. This is the final pullback. The MSAs at LED ostia distal left main is pretty good. At left main it is 14 mm square. At LCX ostia, this is the final pullback. Virtually no plaque. We had completed this with a drug-eluting balloon. This is the 8 appearance right at the distal LM polygon of confluence. You can see the beautiful LCX ostia as well. So the key highlights are that angiographic culprit identification can be unreliable in ACS, especially with a large thrombus burden, particularly in bifurcation anatomy and a presence of prior stent implantation. Systematically applying the AVIS protocol, starting with aspiration, giving vasodilators, imaging, then planning the stenting. This really helps us reclassifying our lesions, and HD-IVUS provides a critical mechanistic insight. And thrombus migration from a non-culprit vessel should also be considered in situations where it's thrombus adjacent to a large bifurcation. And in this case, IVUS guided the PCI, and drug-eluting balloon has offered a beautiful insight in managing such bifurcations without giving additional metal load at a site where there was definitely no disease as per the history in the earlier angiograms. Thank you very much.
Thank you, Tanuj. Awesome presentation. Now we have moved forward from ISRs and chronic lesions to now acute coronary. So, do you feel there are some concerns of use of DBs in thrombus containing lesions, because that remains a relatively no-no?
Yeah. So that is right. Means we are still trying to explore the role of DEB, especially in acute thrombus containing lesions and even in high lipidic vulnerable plaques. So that is still a matter of further research that we require. But maybe we'll have more data, especially when the plaque burden is low. I was not very comfortable not doing or not putting in a stent at this point.
Absolutely. I would have also done the similar way like you have done, and especially in young MIs with the, PAMIs, what we do sometimes, we don't find much of a plaques, only a thrombus which we aspirate, and we try to, we attempt to paint it with a DEB usually. So this is one more example that with a side branch, and especially with no much lesion, you can do that. Only thing is, I don't know the long-term result with the thrombus containing lesions as your case. So probably with the data more coming, we will be more comfortable, and no, the confidence will grow much.
Yeah.
Yeah.
But excellent case. Yeah.
Only thing is you have to apply this the balloon for a longer time. Maybe we are not sure because of the thrombus, the drug delivery may not be ideal. So if you inflate for say rather than 60 seconds, you inflate for 90 milliseconds. That might deliver the drug better. I'm not
Sir,
sure.
So we aspirated as much thrombus, and
Yeah,
after
that
aspiration, we
you
were
have
very
seen the
sure
IVAS also.
that the on the IVUS we did not have any residual thrombus.
Yeah,
Only
yeah.
then
So,
we went ahead with that.
yeah.
only concerns remain, you know what, with the thrombus containing and with the continuing when we are dilating and we are getting a prolonged dilatations with the no reflows.
Yeah,
Sometimes,
yeah,
you know, you have a concerns for re-thrombus generation, and other is that if the particles go down, dislodge down, they
yeah.
can cause some injury to the distal vessel, which is, you know, documented thing also that with the prolonged and high pressure dilatations, you may have that embolization of the drug.
Yes.
Otherwise, absolutely excellent presentations, demonstration how we should do these kind of lesions. Thank you, Tanuj. Anybody
Thank you.
else want to come in?
Yeah, so regarding the prolonged inflations, as you mentioned, so sometimes the DCB itself can cause slow flow. So that also has to be kept in mind because these are some particles are released from the coating and they are known to cause slow flow because of the excipient which is there. So that is another concern. Otherwise, it was a excellent case. I must congratulate Dr. Tanuj.
Thank you.
Really nice.
Thank you. Thank you, sir.
Absolutely. So, thank you, Tanuj. We'll
Thank you,
move
sir. Thank you.
forward.
Thank you.
And so we are now exploring more and more newer avenues for this DEBs, starting with ISR, small vessel, now with bifurcation, especially with the ACS setting. So now we'll move forward with one more presentation with Dr. Ashish, and probably he will be discussing about the role of DCB in, you know, his case presentation, his bifurcation especially, right, Ashish?
Yeah, yeah.
So Ashish is from Max Noida, and I welcome him. And please go ahead and present your case.
Yeah, so thank you for the introduction. And is my slide visible?
Yes, sir. It is visible, sir. Yes, now it's full screen, sir.
Oh, okay. So, thank you for the nice presentations. And now we move towards the bifurcation lesions with the DCBs, which is a new era nowadays. And as we have already discussed that we have moved from a plain balloon angioplasty towards the DES, and now with the DCBs. Now DCBs have come again. They were introduced quite some time back, but now again they have been reintroduced with newer technologies and newer delivery systems. So we are exploring these avenues much further in complex lesions and especially bifurcations. So as mentioned by our previous speakers that the DCBs have anti-proliferative drug coated to the balloon. So the aim is to reduce the late instant failure and treat more lesions with fewer stents, and to mitigate lower bleeding with the prolonged DAPT. That is also one strategy. And the recommendation nowadays is for ISR, but there is a growing evidence for de novo lesions also in small and complex lesions. Function as a semi-compliant angioplasty balloon coated with a lipophilic drug, which results in a rapid absorption of that drug during inflation. And the concept of leave nothing behind, that ensures a homogeneous drug delivery, which is ideal for a complex anatomy such as bifurcation, small vessels, and restenotic lesions. So the concept is that the drug is rapidly transferred and sustained in effectively to a target neointimal hyperplasia, and the efficacy of the drug depends on the concentration, balloon coating composition, and the application techniques. So there are various balloons in the market, and there are various excipients also through which the drug is delivered. And the two common drugs are paclitaxel and the sirolimus. But nowadays we are using more and more paclitaxel only. Just a moment, sorry. Some glitch occurred. Just a moment. Yeah. So why is the paclitaxel drug of choice? So as we know that DCB acts in the G1 phase. So basically there is a cell cycle where there is a G1 and the S is the synthesis phase, then there is a G2 phase and then the M phase. So basically the DCBs act at the junction of G1 and the S phase, both the paclitaxel as well as the sirolimus. But paclitaxel is the preferred drug for short-term exposure due to high vessel wall absorption and the ability to reach the adventitia. Paclitaxel also has a shorter half-life, that is 6 to 13 hours, compared to the limus family, which has a 60 hours of half-life. And this is a highly lipophilic, and paclitaxel remains in tissue for a longer period despite its brief exposure. So just 60 seconds of exposure leads to a paclitaxel being absorbed, and that lasts for around 14 days. And in effect, the effect on the vessel wall diminishes after 14 days, which supports the natural healing, and it promotes positive remodeling, and the apoptotic risk is also reduced, allowing uninterrupted endothelial growth, and this results in a quicker vessel healing, faster endothelialization, and reduced need for a DAPT therapy. So initially when we remember that the Taxus stents, when they were being used, so the results were not optimal. So that is why the limus family came into picture, and the reason behind it was that the Taxus contained a higher amount of paclitaxel, and that resulted into a far more apoptosis of the endothelium, and that apoptosis led to non-healing of the lesions, leading to more SATs, and then maybe after some time there was a rebound hyperplasia, so more ISRs. So the apoptosis was one factor which led to removal of the paclitaxel eluting stents. But now with the drug coated balloons, the paclitaxel amount is reduced in the drug DCBs, and this amount is insufficient to cause apoptosis. So that leads to better remodeling of the vessel and no apoptosis of the endothelium. So regarding the bifurcation, we all know that 20% of the bifurcation lesions we encounter during our routine PCI, and they are technically complex and associated with the high risk of adverse long-term outcomes. The conventional approach is the crossover stenting, and if that is a provisional stenting, and if required, a two-stent strategy if there is a complex lesion. And evidence of DCB after ostial side branch dilatation results in a late lumen loss of around 0.13 millimeter versus 0.51 as compared to the DES, and the binary restenosis is 6% versus 26% at 9 months. So the DCB only approach avoids a carina shift, but it is technically challenging with the risk of dissection or perforation after kissing balloon dilatation. So there is always a risk when we use a DCB in bifurcation. So finally, after doing a kissing, if we find that there is a dissection or a flow limiting phenomena, if there is a chest pain or an ECG changes, then we may switch over to a bailout stenting strategy. Otherwise, DCB can be used as a only approach. While DCB plus atherectomy at 12 months, the TLR was around 10.9 and a binary restenosis was around 2.3%. So these were the initial data which prompted us to use more DCBs in the bifurcation. So the advantages are that the drug delivery is homogeneous and it preserves natural anatomy, avoids any polymer related complications. The DAPT duration can be reduced further, and there is a reduced thrombotic risk because there is no polymer, there is no metal scaffolding. So all of these things are taken care of by DCB because there is nothing which is left behind. And the strategies can be used as a hybrid approach where the DCB can be used in the side branch and the DES in the main vessel, or a total DCB approach that is in both the main vessel and as well as in the side branch. So what are the treatment options of side branch in a coronary bifurcation lesion? So DCBs may help preserve the vessel patency and have potential benefits that is we have discussed in the previous slide, that reduced risk of thrombosis, reduced risk of progression of the plaque, better angiographic and clinical outcomes, and reduced TLRs. So what is the clinical evidence with the DCBs? So recently a DCB BIF trial was done where the almost 858 patients were recruited and both the vessels were jailed, and so the side branch was also wired, and out of this around 784 patients were chosen who had a ostial side branch stenosis more than 70%, and they were equally divided into two groups, which was a DCB versus a non-compliant balloon group. And then it was found that the MACE was significantly lower when the DCB was used. So the difference was around 12.5% in the DCB versus 7.2% in the non-compliant balloon. And it was composite of cardiac death, target vessel MI, or a clinically driven TLR. So this was a provisional strategy. While if you look at the HYPER study, it was a hybrid strategy consisting of combination of DES and a DCB, and it was found that it is feasible and safe option for bifurcation lesion, especially with a small caliber side branch. And treatment provided a high rate of procedural success even in complex lesions which may require two-stent strategy in a clinical practice. And the good clinical outcome persisted even at 1 year of follow-up with no events related to DCB treated segments. So this was also a study which prompted us to go for future studies, and a review and meta-analysis which showed which comprised of 5 RCTs and 5 non-randomized studies. They took around 934 patients, and the angiographic follow-up was around 9 months. So there was a less late luminal loss and less diametric stenosis, less binary restenosis in the DCB group compared to the non-DCB, and the MLD in the DCB was more than the MLD in the non-DCB group. And MACE at 9 and 12 months follow-up, there was a significant reduction in the MACE with the DCB compared to the non-drug coated balloon. So in conclusion, DCB had a great effect in the side branch protection for de novo bifurcation lesions at short and medium term follow-up with no reduction in the procedural success rate. So again, another meta-analysis, again, they also found the same thing, that the DCB demonstrated superior angiographic and clinical outcomes as compared to the non-drug coated balloons. So, and there is a Pearl registry which specifically used a protease balloon, and the background was a ISR and a small vessel disease, which were challenges for a PCI, and DCB provided an alternative to the stent implantation. And the objective was to evaluate the safety and efficacy of protease in a real world PCI practice. So the design was a multi-center prospective and observational registry, and the population was around 513 patients, where the ISR was around 382 and the de novo lesions were 131. And the primary endpoints were 2-year MACE, which was a cardiac death, target vessel MI or a TLR, and the secondary endpoints were revascularization, lesion thrombosis or a procedural complication. So the key findings were that at 2 years the MACE rate in terms of ISR was 17.1% in the ISR group and the 9.7% in the de novo group, while the TLR cases like ISR was 11.7% and the de novo lesion was 2.9%. The complications rate were very low, that was around 3.3%, and only 3% of the patients required a bailout stenting. And the predictors of MACE in ISR was the lesion length and a history of CABG. So clearly we see that in de novo lesions, the protease balloon fared much better as compared to the ISR. So in conclusion, protease paclitaxel DCB is safe and effective for ISR and de novo lesions in the real world PCI, and outcomes support DCB as a viable alternative for complex and high risk cases. And the clinical implication was that favorable for ISR and small vessel PCI without leaving a permanent stent. So this was the conclusion from the Pearl registry, and this was done before 2019. So this balloon was there in the market, but the usage was not so optimal. And there are few studies which are ongoing, like a hybrid DEB study, and then there is a provision DEB study which are actively recruiting the patients, and these studies have a follow-up around 2 to 3 years, which will come up in the coming years. So the recruitment is going on. So with this background, I have a case to present. This is a patient, 74 years old male, diabetic, hypertensive and dyslipidemic, presented with the ACS non-STEMI, had a relative anemia, hemoglobin was around 9.5, and he had an AKI also. So the patient's creatinine was around 1.9, which we gave some hydration and other therapies, which improved to 1.3, and the ejection fraction was 50%. So this is the angiogram. So here we can see the LAD is nice, flowing some plaque in the proximal vessel and a calcified lesion. And this is the circumflex where you can see that there is a big OM coming in the proximal region, and the distal circumflex also showing some lesions. So this is a 011 Medina classification where you require a 2-stent upfront strategy if you want to put stents in this patient. So what we did was, this is the RCA, this is also a relatively non-diseased artery. So again, another view. So here you can see that the lesion is 011. So if we took a stent, we would have implanted 2 stents and using probably a crush or a tap technique. So for that, we first did an IVUS in both the vessels and found out the reference vessel diameters. And with that, we did a preparation of the side branch first. So this is a 1.5 into 18 millimeters balloon. And then this is a 2 into 15 millimeters balloon. So after that, this is the result. This is the angiographic result. So here you can see that the lesion is well prepared, and also the distal vessel is flowing in a TIMI3 fashion. So there is no flow limiting dissection. There was no ECG change, and there was no chest pain. So with that, we did a IVUS run again into the side vessel, and sorry, I don't have the images of the IVUS, but the lesion preparation was really nice. And so this IVUS is after a 2.5 into 18 millimeters of balloon. So the balloon was inflated for around 60 seconds and at around 10 atmosphere pressures. So this IVUS was taken, and we found that there is no residual dissection over there. And then we prepared the main vessel. And then this is a DCB which we applied in the side branch. So this is a paclitaxel balloon, 20 millimeters in size, 2.5 into 20. And after that, the result is excellent. There is no flow limitation, there is no dissection. And then because the distal LCX showed recoil, so we thought that let's stent the circumflex at least. So we took a long stent, that is a 48 millimeters of a stent. And this is a 2.5 into 48. And so this is the angiographic result. And then we did a pot with a 3 millimeters balloon. And then distal vessel was optimized with a 275 balloon. So this is the final angiographic picture. So as you can see, some ostial pinching is there, but still the flow is good in both the vessels, and there is no limiting dissection. So this was the final angiographic picture. So take-home message is the clinical outcomes with DCB showed long-term clinical efficacy and safety in treating side branch. DCBs are associated with superior angiographic outcomes compared with DES, and DCB is an attractive and safe option in the treatment of coronary lesions. Thank you.
Okay, Ashish, thank you so much. Nice presentation. Only thing I would have suggested that why did you ever think of putting even other DB also in the main branch? Because again, putting a longer stent sometimes just ruins our purpose of maintaining a good long-term patency. That is the concerns. And
Yeah. So,
you put up 2.5, right?
sorry?
Size of the stent was 2.5.
2.5 because of the distal vessel diameter was 2.5 on
So
IVUS.
did you ever think of putting a longer balloon only, DB?
So yeah, that was in our mind, but because there was significant recoil. If you look at the LCX after dilatation with the 275 balloon in the proximal part, there was a significant recoil. So we thought that even if we put a DEB, it might recoil further and may require a DES. And there was some budget problem with the patient also. So anyhow, in that long lesion, we required a 2 DEBs also. So that would have added to the cost. So we thought that let's go for a DES as a final solution.
Fine, fine. Nicely done case. Anybody else also want to chip in? Want to comment about the case?
So I think I also will consider the putting the dev in the manual 6 also.
Yeah, agreed. That was my choice also. But since there was a recoil after doing a pre-dilatation, so I thought that if at all the vessel requires, then I would have to put another DES. So now the recommendation is that if you put a DCB, then putting a DES, we don't know about the 2 drugs acting together on the vessel wall. How would it behave, first of all? So, I mean, only in bailout strategies it can be done. But if you feel that after lesion preparation there is a significant recoil, then one must opt for a DES than going for a
And
DEB.
did you think about just leaving the side branch and just putting a DB in the main branch only? Means
Yeah. So
because of the
basically, but
smaller size, sometimes you try to do good and you land up with some dissections and you have no choices with the smaller, branches.
Agreed, sir. But the question problem is that that lesion was very tight, and when we did an IVA, we found that the vessel was at least 2.5 millimeter.
Okay.
So that prompted us to use a DEB. Otherwise, I would not have dilated. But with after 1.5 dilatation, I took an IVAS run and found that the vessel size was good. Actually, it grew in size after dilatation.
Okay. Agreed. Nicely done.
No,
So
only thing I would have the same bed preparation of both the vessels would have been done first. You see what is the response to the LCX. If you have seen that the LCX is recoiled, then you put a stent and then recross to the D1, this OM, and then you put a DEB. Because you already applied DEB and now you have put a stent, there is a pinching. So if had it been there before, then you could have crossed again and then you do DEB last.
actually, I'll like to show one case in the end where DB should be the last thing to be put. Suppose you have used a DB and then you're putting a stent and manipulating, that doesn't fully serve our purpose of painting it. So probably Ashish, in the next time you have such case, try to put the DB in the last.
Sir, I have I research a lot on this topic actually. So I found, yeah. So
Depending
actually,
upon,
that
yeah.
was my concept. But when I found the literature, it is quite the contrary because they say that if you are treating a side branch, don't go through the jailed, struts because that may cause the drug to dissipate while crossing. Secondly, because of the stent already present at the mouth, the drug is not delivered at the ostium of the side branch. So this is the concept which has been written in the literature, especially if you go for the that Fezzi article in the Euro intervention.
No,
So in
no,
October
no,
25
no.
also they have
Ashish, no. Probably if you dilate it nicely and you have a bigger size above, like your case, you dilated with 2.75,
yeah.
right? Then you will definitely have a good lumen. Like in last case, what Tanuj did. If you have side branch, all of course it has to be done after once you are done with the pot as well, because that is last thing you want to do. You don't want to touch it again and again. What I this is my concern.
So, yeah, sir, I agreed. But then that this concept is being explored. So till now, the data suggests that you do a DEB, but then don't do anything at the side branch.
Now
So
your got pinched. Now what are your strategy?
yeah, so that is what. So angiographically, if there is a 30% restenosis, that is acceptable. So actually, it is 40% if you look
No,
at the
whatever the
literature.
stenosis, even if you can't do now FFR also, you're putting a wire can also disrupt that integrity. So, of course, what you say is written that you do a sidebar first, but that is maybe probably for the smaller D1s. For bigger arteries, like if you have a left main bifurcation, I will always try to do it the last. This is what I would have done. Otherwise,
Yeah,
what you did was
agreed.
correct. I agree.
Yeah, so this concept is being explored actually, sir. So to be
Yeah,
frank,
so
this
we
is
are
being
still
explored.
learning
So
on
we
this issue.
don't
Yes.
know the real,
Yeah,
outcome,
Absolutely.
how
we
which is
also,
better and which is not. So
we have a lot of controversy on this.
yeah.
Yes. Thank you, Ashish. I will move forward and will like to introduce Dr. Ankur Gupta. He will talk about DCB in the small branches and, of course, in the side vessels. Over to Ashish.
Hi, good evening, everyone. I'll just share my screen. So I have a fairly small and a very straightforward, simple case. I'll start. So I had this 53-year-old male patient. So he presented with ACS. He had NSTEMI. Troponins was quite elevated. Ongoing chest pain was there. Echo showed RWMA in the inferolateral territory, and EF was around 40 to 45%. So he was taken for angiogram. So there was this distal LCX, which was 99% thrombotically occluded, and with some faint retrograde collaterals. I'll just go to the angiogram. So you can see in this view, this is the distal LCX, around 99% occluded, and TIMI 1 flow. Since the size of the vessel did not look quite big to me, and it was a distal LCX, so I thought of rather than going for a stent, I thought of using a drug-eluting balloon. So the lesion was prepared first with 1.5 millimeter balloon and then with a 2 millimeter balloon. Then 2.5 millimeters protege balloon was taken, and inflations were given because we can give multiple inflations with this. So this was the final result. TIMI-3 flow was achieved. We can see there is still some thrombus over there. So patient was kept on agramet and was discharged in hemodynamically stable condition and was also asymptomatic. So PTCI with DEB to the thrombotic occlusion was done, and this DEB protege DEB demonstrated excellent deliverability and expansion in the LCX following effective pre-dilatation with good tolerance in a thrombotic occlusion. So patient is on follow-up. It's been 6 months. Patient is asymptomatic, and his ejection fraction has also improved to 55%. There's no RWMA now. So this was I think, fairly simple and a straightforward case where since it was quite distal in LCX and the size of distal LCX was also small. Initially, first I thought that if it's too small, why not leave it as it is? But since the patient was having pain also, it affected ejection fraction a lot. It was around 40 to 45%. So then I decided to go with drug-eluting balloon rather than stent because of the small lumen that took quite distally in this patient.
Thank you, Ankur. Short and sweet, nice case, nice demonstration that we can use them in our small vessels, especially ACS. If it would have been a chronic disease and you have some other disease along with that, so I would have left this, sir. But because of ACS, you are quite justified in using that, and probably DB made your life easier. That you could, go asleep nicely without much tension because of that. A good result overall. So nice case. Anybody wants to want to comment?
On top of that, this segment was tortuous. So the
Yeah.
geometry of
Yes.
the vessels was maintained. So you
Absolutely.
have better vasomotor function after this thing rather than putting a stent.
Absolutely. So DB makes our life easier sometimes with tortuosity, smaller vessel when we fear either dissections or tracking the stents. So probably this was a better demonstration how you should use in a smaller vessels. Thank you, Ankur. And probably somebody wants to come in, or we will move forward. So we'll come to our last session for today. This is by Dr. Siddharth Samrat. He's from Numed Hospital, and he'll be talking about the hybrid approach for treating diffuse diseases. So Siddharth, please share your presentation.
So I am presenting a case of disuse of DCB in ectatic coronary artery as well as a diffuse L6 branch. So this is my case. He was a 54-year male, came to us with severe chest pain since last 30 minutes, and pain was radiating to left arm, and it was associated with sweating and uneasiness. He has history of hypertension since last 55 years, and he has a significant history of left kidney donation 15 years back to his elder brother. These are the ECG on arrival. Here we consider the ST depression is present in the inferior leads as well as in the V5, V6. On arrival, his BP was quite high, 152/98 mmHg, and he was also quite heavy, BMI was quite high. And on chest examination, it was unremarkable, and there was pulse rate was a little bit higher side, and he was having severe chest pain. So this was the initial investigation. TROP-I was initially negative, but when we did the TROP-I after 3 hours, it was quite high. And his liver profile was also quite high. LDL was 150. And his creatinine was a little bit higher side, 1.3, and urea was 28. And on the 2D echo, ejection fraction was approximately 48%. And ultrasound Raman was also done because he has history of kidney donation. So it was showing the left kidney was not visualized, and in right side kidney was enlarged in size. So our plan was to go for giving the immediately antiplatelet antiangiogenic and low molecular weight heparin, and further he was shifted for the coronary angiography 6 hours after the admission of the patients. And in view of raised creatinine in single kidney, we have started hydration with normal saline at the rate of 1 ml per kg per hour, and taken nephrology consultation before the coronary angiography. So this was the initial angiogram. It was suggestive of the in the LAD, here we consider diffuse ectasia in the proximal part was present, and in the L6 also there was proximal ectasia was present, and the distal L6 was having the diffuse disease with 90% stenosis with multiple focal ectatic segments. In the LAD, here we can see that there is mid part near the diagonal, there is a significant stenosis of 90% present, as well as slow flow was also present. In the right side artery, here we can also see that there is diffuse ectasia is present. So in view of the raised creatinine and the diffuse ectasia, as well as the small distal LCX, we did not go ahead with the angioplasty with the DES, because there was chance of the malopposition and stent thrombosis if we go in stenting with the DES in the ectatic segment. So patient was kept on the tyrosine infusion and with the other antiplatelets and anti-angiogenic treatment. And the next day, his creatinine was also raised from 1.3 to 1.4. So we continued hydration and other supportive medical treatment. So we planned for the drug-coated balloon angioplasty, as there was high risk of stent malposition because of multiple ectatic segments, and stent thrombosis in the ectatic segment is quite high with DES. So next day, we planned for the angioplasty with the minimal use of dye. So we first wired the LCX and pre-dilated with the 2.5 into 10 NC balloon, and we took the 2.5 into 30 after bed preparation, 2.5 into 30 protege, and dilated for the 30 seconds 3 times in the LCX segment. And after the dilation, we considered the distal part and the proximal near the ostia, quite good result is present. In the LAD, we also took the 2.5 into 10 and 3 into 10 NC balloon is really dilated, and then we took the DEB protege of 3 into 20 size and dilated it for the 30 seconds 3 times, and there was no dog boning after the dilation, and after the 3 dilation there was no significant residual stenosis, and TIMI flow was present in both the artery. So in that way, patient was both the LAD and L6 was angioplasty was done with the help of DCB. And at the end of the procedure, there was no chest pain, and the ECG was there is also no residual changes in the patient. And after two weeks of the follow-up, patient is completely pain-free, and there is no residual chest pain, and ECG is absolutely normal. So as sir has shown this diagram here, we can few of the subsets where we can use the DCB, like in ISR lesions, a small vessel with very small vessels, or late large lumen dimension, like in the positive remodeled vessels, or diffuse disease, or large vessels, or calcified vessels, or chronic bifurcation lesion, or CTO lesions, or the patient when we have those who are having high bleeding risk. In that subset of the patients, we can use the DCB, and these are the, as sir had shown in the initially, Sarma sir. If we are planning for the DCB, 1:1 balloon dilation is must, and after the 1:1 balloon dilation and atherectomy devices if needed, there is no flow limiting dissection, and there is no residual stenosis less than 30%, then we can go for DCB. But if there is residual stenosis of more than 30%, then we have to put the stents. Thank you.
Hi, Siddharth. Thank you. Nothing to take away from your case. You did nicely, but I had 2 concerns. One, that paclitaxel is known to cause positive reporting.
Yes,
So
sir.
with actadia around, I would not
Yes.
use paclitaxel. One. Secondly, with the small segment what you had in the mid LED, I would just put a small DES in that from the starting from the end of the ectatic till that lesion. That would have solved my purpose. Why? Because DES has been, standing since many years. They have stood the test of time, and we are quite comfortable using a small DES rather than having a very small risk of restenosis as well as thrombosis. Third, my concern were about that branch in which you use DEB. I would have left it like that for the reason that the patient is already having a CKD with ectasia around, and that was not a very big vessel to tackle and would have caused any symptoms. Otherwise, what you did was absolutely okay. I have no issues, but that was my concern, which I just want to have open of the panelist.
Okay, sir. Thank you.
And one more thing. Once you had planned on the second day, imaging would have been helpful, because if you have ectasia before and after that, you don't have the idea what is the true diameter of the vessel. So it is just a
Sir,
resumption.
in the
Yeah.
LED, there was quite size mismatch. Ectasia was more in the proximal segment, sir. So,
If you have ectasia after the stenosis and before stenosis, the
yes,
true diameter of the vessel is not understood
right, sir.
by angiography. So imaging would have been helpful.
Yes.
Nice, Siddharth. Thank you so much. So probably we are coming to the end, and before we end, I want to show one case which will have all the subset what we have talked: small vessel, diffuse lesion, bifurcation. So that will like our cherry on the cake. Let me present one of my case, and we'll have the opinion of my esteemed colleagues. So can you see my screen now?
Yes, sir.
Okay.
Just the slideshow, sir.
Sure. So, my patient was a 49-year male diabetic hypertensive having unstable angina with T inversions in anterior lateral leads. And angio was quite horrifying to see with all the vessel involved with distal left main and a disease which was quite diffuse. So this was the disease of the patient. You can see this triple vessel disease. And lesions were quite bigger in all the three subsets. So we thought of, this was in 2019 probably, and he was not willing for any bypass, so we planned for a stenting, and that time DEB was not that quite easily available, and we were not that well versed with their usage. So we thought of doing either double or triple stent. So these were the two main branches to tackle, Samus and LED, and circumflex. Being a circumflex, we thought that we'll tackle that as well. So we planned for doing what we term as a double decay crush. So what we do in this is that we deploy two branches, side branches, stents, and then we crush it with a third main branch balloon. Then we take a third, first triple kiss, then do a third stent in the main branch starting from the proximal part, and then we do final tracing. So this we did with the first tackling the mid LED with the longer stent, then proceeded for a double decay crush. As I mentioned that we took two stents, two deaths in ramus and circumflex, and then one balloon was kept in the main LED. We crushed that two stents with that balloon. This was the first crush, what we call off as the first crush of double decay crush. This is how it was done. This was then the first triple kiss, and for this we have to use two guiding catheters. This is known as a ping pong technique, because in one 7.5 two balloons only can be accommodated. After this, we took a stent from left main to LED. We did crushing with the second crush with this longer stent, with the third stent in the left main to LED. Third kiss, second kiss, and this was the tracing. The three balloons were taken with the two catheters, and we have to dilate both the three stents who are opposed together. Finally, we did some post-stenting optimization of the proximal and the mid LED and circumflex. And this was the final result. So we thought that we did reasonably well in this case, and we will just get out of this. And we just call it a day. And patient was doing fine for maybe 3-4 years. He was quite compliant, but his sugars were not that into a good control range. After 9 months, he again comes with a classical angina, and this was the angio this time. You can see the LED stent is flowing well, but you have a two stenosis, instant restenosis in the ostial segments of both LCX and the ramus branches. And this is the major, what we can say as a problem with the desk, especially with the bifurcation stenting. That once you have this, you have a quite a difficult times to tackle, because once you have three stents, putting again a stent into that bifurcation, and that to the left main becomes more riskier, and you will yourself not try to do that. And thirdly, that when you have a good LED, subjecting the patient for CABG would again not a rational approach in this case. So what we did was we discussed with the family, and we thought that we'll do DEBs to the side branches, and this is what we opted for. We have to tackle this bifurcation now. Leaving apart the LED, we have now a bifurcation stenosis in the circumflex and the ramus bifurcation. And after discussing and ruling out the possibility of CABG, because of these some concerns, we thought of doing a plasty with the DEB. So what we did first kissing balloon with two NCs in LED ramus. Then with the other catheter around, we cannulated the circumflex like we did in the previous case. Did a triple kiss with 3 DEBs in all the 3 branches. We took 3 DEBs for the reason that it was a quite a 9-month-old stent. So DEB, their drug must have been washed away from all the stents. And we don't want to compromise LED for any reason. And for other 2 branches, we didn't want to compromise on the chance of restenosis. This was the final result with these 3 kissings. And patient is now more than now 2 years. He's doing fine. And hopefully he doesn't have restenosis. I have not checked it myself, but he's doing okay. And probably this was DB which saved my day. Otherwise, I don't know what I would have done this time. So I'll stop here, and if there are some comments, I'll be happy to discuss the comments, and there some questions is there.
I must say, wonderful result at the end.
Thank you, Siddharth. So probably DB has the latest in thing, and yes, sir, go ahead.
It has made our life much easier, because whenever you have difficult lesions and you should plan, you straight away go for DCB first, and stent should be your second strategy, because it makes our life easier, and the patients will not be on long duration DAPTs. And another concern is you can always have a stent later on, but once you have a stent in, then second stent is a bit difficult.
Absolutely. What DES did 10 years back when it was introduced with the Cordis, and with the first in the man study, that the zero restenosis, everybody was like putting a DES everywhere. Now the things have shifted from DES to DB. This is the revolutionary thing what has happened, and probably with time to come, we may have something more indigenous or something hybrid, in the sense that maybe you have something like DEB, but slightly thicker, which can give some scaffold, and with time that will get dissolved, and you will have a native vessel like what the absorbable stent were doing before.
Exactly.
So probably this is a way forward, or a step closer to achieving that in the future. So thank you, Dr. Ranjan, and thank you all my colleagues for chipping in and presenting the nice, extraordinary cases. And I'll thank Translumina for giving up opportunity to discuss and learn ourselves in this platform. And thank you from my side, and over to you, Garimana.
Thank you so much, sir. And a huge thank you to all our faculty members today, and for, because of you, the attendees, and we all have learned so much about DCBs and the emerging technology. I would add on this that not all the expertise has adopted this, but still it is, an emerging technology in the modern era of PCI. So looking forward for a collaboration maybe in the near future again. Thank you so much. We appreciate your time sharing the insights. Thank you. Have a great
Thank
evening.
you.
Thank you.
Okay.
Thank you, everyone.
Thank
Nice
you.
connecting. We'll again connect. Thank you. Bye.
Thank you.
Thank you.